My name's Toby Reynolds. I'm an anaesthetist. I work in Barts Health in Whitechapel. I think partly because I used to work with the standards and ethics team in the GMC, I've been invited to help this session, which is all about professional judgment. It's use your professional judgment, what do the regulators mean? And this comes out of experiences that professionals had during the pandemic when there were a lot of extremely difficult decisions to be made, and when the circumstances, the way in which those decisions had to be made was lacking the framework that we normally benefit from. There's an extremely interesting piece of work done for the Professional Standards Authority by Deborah Bowman that looked into practitioners' experience of ethics and trying to make ethical decisions during the pandemic. And many things came out of that report, but one of them was a focus on professional judgment. Regulated professionals were, I think, prepared and accepted the idea that they needed to use professional judgment to make their decisions in an ethical way, but they didn't necessarily feel that they would be supported to do that by their regulators, and they didn't necessarily feel confident that they wouldn't be scrutinised unfairly afterwards. So I think that's the background for the subject for this workshop, which I think is going to be absolutely fascinating. We're very lucky to have two experts with us, Alexis Payton and Richard Huxtable, who are both going to give short presentations on work that they've done into ethical decision-making and the role of professional judgment around the context of the pandemic. So perhaps the best way to start is to invite Richard up first. So Richard is a Professor of Medical Ethics and Law at the University of Bristol. He's the Director for the Centre for Ethics in Medicine, which is based within the medical school. He's currently the chair of the UK Clinical Ethics Network, and he's worked with the ethics committees for the BMA and the RCGP. So Richard will speak first.
Thank you, Toby, and thank you indeed to Sharon and the team for the invitation. So I'll be speaking to this title, Ethical Guidance and Support, and picking up indeed on our chair for the day, Samira Ahmed's reference earlier to lessons learned. So identifying some lessons we might learn from recent activity around ethical guidance, ethical support. And I should also briefly thank colleagues with whom I did some of the research I'll draw on in this short presentation, but should emphasise these are very much my own views, and indeed not necessarily those of committees, including ethics committees that I work with. So what do I plan to do? Well, I plan, first of all, to look back at the activity we've seen, particularly in the last 2 or 3 years, around ethical guidance, around ethical support, and indeed support and guidance to help support individual professionals' judgments. And on the back of some of those reflections, I hope to help us look forward. And indeed, I'll point to 4 headline messages. 2 in particular I'll emphasise for reasons of time, but I think all 4 of which have something important to say. So if we start by looking back, then you might well recall, you might have been amongst those, myself included, who early on in the period around about March to May 2020 were asking where is the authoritative national ethical guidance to guide judgments during the pandemic. And there were various such pleas, but part of the good news was various organisations did rapidly step forward and provide guidance. And there's a snapshot of some of the organisations that did so on the right-hand side of the slide. And then working with colleagues in Bristol and beyond, we undertook very much a rapid review, understandably, I think, of the guidance that had been issued around about by the middle of May of 2020. And we were focused on England and Wales, and at that point we identified 28 pieces of guidance. I think many more were forthcoming afterwards, and indeed in all 4 nations. And there were some good pieces of news within there. So we were finding evidence of communication, of collaboration between the different groups, and indeed, as you'll see from those principles on the slide, a high degree of convergence. So a general sense that the organisations that stepped up and provided the guidance felt that these 13 principles were the key to guiding judgments throughout the pandemic and perhaps beyond. But the guidance recognised, including guidance from the Royal College of Physicians, that guidance alone would not be sufficient. There would also be need for support mechanisms to help professionals to reach the relevant judgments. And one of the obvious places that was looked to, and we saw an expansion in activity on, was clinical ethics advisory groups or clinical ethics committees. And broadly, they have three key functions, the first of which is around ethics education, but certainly during the pandemic we saw a great deal of emphasis on ethical input into policy and guidance, and also some assistance with individual patient care. So advice, very much advice, on individual patient cases. And at the moment we lack a formal structure for this activity, but the closest we have is the UK Clinical Ethics Network, in an effort to try and put these different groups in contact with one another. But just briefly to note some of the developments we saw during the pandemic around these support services, there are two really. One was around the number of such services, and the other is about the nature of the services and indeed the locales that they served. So in terms of numbers, we have some studies out there, including by colleagues in the room, giving snapshots of numbers at various time points. And it looks from this graph that the high watermark was around about 10 years ago, around about 80 or so such groups. The most recent study suggests there were only 36 groups, but personally I'd add I suspect there are many more than that. It was because these are populated by clinicians and indeed others, they probably lack the time to engage in surveys. But the latest snapshot says 36 or so. But the other striking development was we saw these groups not only being formed at local levels, for example in a hospital trust, but also at regional and county levels. So I think implicit in all of that is some good news. There was guidance out there, there were sources of support in addition to help professionals reach the relevant judgments which would inevitably have an ethical dimension or dimensions. But what should we learn? As I say, 4 brief messages. The first is a key message around clarity and accessibility, ensuring that anything we have in terms of guidance and support going forward is clear and accessible to those who need to use it or indeed will be affected by it. A clinical colleague in intensive care in Bristol, Ian Thomas, remarked to me early on in the pandemic that there was a great deal of confusion behind what he called the COVID fog. And we certainly heard perceptions, as I mentioned a moment ago, that there was too little guidance, too little support early on, and then it quickly became the case that there was too much guidance, and indeed a perception from professionals that such guidance as there was, as Professor Bowman's report notes, was really too late. So I think there are various lessons to work on there in terms of, for example, coordination. If we think about coordination, recall that point I made about local groups plus regional groups. How do they interact? How can we ensure that it's clear to a professional, for example, which group to approach? There are also lessons around the guidance, particularly when the field becomes crowded and noisy. How can the professional know which guidance to pin to the notice board and which one to bin? So that would be one of my first lessons. The second would be about ensuring a degree of consistency. We can discuss what degree we need of consistency, but a degree of consistency at least, and coordination of these different services. So a few remarks to make regarding this. If you think back to those 13 principles I briefly flashed up on the screen, then immediately you might think, well, that's well and good. They would appear to be useful. But what about situations of conflict or tension? How do we navigate between the principles and indeed balance them? And unfortunately, so far as we could tell, the guidance didn't offer a method for navigating such tensions or conflicts. To illustrate the sort of conflicts we might have in mind is think that there were population-level principles such as fairness, and those can potentially come into conflict with more individualistic principles such as respect. Moreover, in terms of clinical ethics support, there is that lingering question. How do we coordinate the different services? How do they learn from and with one another? And indeed, which group does one approach at the relevant point in time? And there's a big question underneath, which is the theme of this discussion, which I'll just plant an idea regarding this keyword judgment. There's something of a tension itself there, in that we're told that professionals need to exercise judgment, and indeed they'll need to exercise their judgment in working out which service to approach or which guidance to use or not use. But at the same time, we're told that the guidance will inform professionals' judgments and indeed constrain them. So how do we square that circle? Final two messages I'll deal with more briefly, some of which, certainly this one, have come up very loudly in today's presentations. So we need to ensure that we are appropriately engaging and involving those, particularly those affected by decisions made, advice given, guidance issued. We heard various complaints, various concerns, I can illustrate those in a moment with a couple of quotations, around insufficient activity to engage people and help them to co-produce the guidance, for example. There were examples of good practice, and I should confess I was involved to a small degree in the Devon Ethical Reference Group, which issued its own framework, and it was able to engage online with the local population. So there were ways of doing this. But nonetheless, we heard complaints, for example, in the BMJ, that important mantra that we discussed earlier on, nothing about us without us, was being left hanging in the breeze. And strikingly, the courts also got involved, this time in relation to ethics committees, where they felt there needs to be real clarity around when to involve patients and those close to them in, for example, case referrals to such a committee. And the final, and I absolutely acknowledge, most optimistic message is to recognise that a great deal of this activity has relied on enthusiasts and volunteers. So something of a plea for, if the magic money tree is ever found, hopefully a little bit of the money could be devoted to working out how to bring all this together. So those are my 4 key messages, and I will hand in a moment to Alexis, but the sense is that hopefully by attending to these sorts of messages, we can find a way to light our way through the COVID fog that Dr. Thomas referred to. Thanks for listening.
Thank you very much, Richard. So we've all been used to using the app throughout the day. Do think of any questions that you have, because we're going to have a good amount of time to discuss any of the thoughts that you have, any questions that you have later on in the session. One of the other reasons, of course, that we're interested in hosting this debate today is that there's an ongoing review into the next edition of Good Medical Practice, which is going to make the consultation on the revised draft is open at the moment. We hope that everybody will have a look at that. But it does make some slightly expanded comments on the importance of professional judgment. And so everything that is raised as a question today, whether or not we're able to address it in the session, everything will go forward towards consideration of for the consultation for good medical practice, and we'll put up some more details about that towards the end. So if I could invite Alexis Payton to stand up, and she'll be able to give our next talk. So, I should give you that. So Alexis is a lecturer in sociology at Aston University and co-director of the Centre for Health and Society. She's also based within the medical school. And she's been doing a lot of work with the Royal College of Physicians, which she'll be able to tell us about, where she is the chair of the Committee for Ethical Issues in Medicine.
Lovely. Is it on? Yeah. Oh, look at that. Excellent. Isn't this nice to be back together again? I know that there's an online community as well, and hello to you. So thank you for that. And I wanted to kind of follow on and build on what Richard was talking about, in terms of, we know what kind of principles we need to be following, but what kind of practical things can we offer the community as well? And so today I want to talk about an initiative that we did at the RCP called Conversations for Ethically Complex Care. And in particular, I want to talk about a document that came out of that, which is the development of the ethical care decision-making record. So the record came about because of basically the experiences of healthcare staff having to make difficult decisions during the pandemic. And now, I think sometimes we talk about during the pandemic, we're in it, and we're moving into a more difficult road to recovery period as well. And it's important we acknowledge that kind of elasticity of the timings that we're talking about here. But it quickly became apparent that we needed to be doing more to support healthcare staff because of COVID, but then as we started to develop the ethical care decision-making record, we realized this could actually be quite helpful in everyday situations as well. And I think we all know that many decisions that we make in clinical practice are actually quite straightforward, and in general they can be objective or evidence-based, and we know we're making the right decisions. But decisions, especially in the pandemic and beyond, around escalation and de-escalation of care, that's when we were seeing that, actually there were some difficulties there. It was difficult for healthcare staff, it was difficult for the patients, and it was difficult for the family and the carers of patients as well to wrap their heads around what was the right way forward. And in this room, I know I'm probably telling you something you all know and have experienced. And in no way am I showing you new information. We're probably all rehashing what's been happening over the last couple of years. But these decisions can be complex. We know they can be contested, and we've seen really that they are highly contextual, and they might even occur in situations where resources are limited. And that's something where we really need to be thinking about what the future of the NHS looks like. So the ethical care decision-making record was intended to provide a kind of clear framework for ethical discussion that supports decision-making and documentation of that process. So we're using it as an extension of the principles and the guidance that we provided at the RCP, kind of say, okay, well, we told you to pay attention to these principles. Here's something to help you actually put that into practice that's helpful for your practice as well. So, how did we get here? Well, let me take you back to the beginning of the pandemic and the origins of the guide. So very quickly, the medical community realized that there were significant and immediate ethical issues that we had to deal with, and I think we can see those in the headlines at the time. In particular, there was a lot of concerns around things like surge capacity of ICU, critical care, provision of ventilators, and Italy in particular was kind of a scary what could happen situation. As a result, what we saw was that the RCP and the Committee on Ethical Issues in Medicine, well, we began to develop practical guidance to help staff because we knew that there was something that needed to be put out there. And I hope we weren't too late. I'll have to ask Richard later whether we were too late or too early or right on time. But we produced this ethical dimensions for COVID-19 for frontline staff. And this document has really guided us throughout. But something else was happening. There's appendices as well, should you need them. At the RCP, several doctors were starting to contact us individually. And they were telling us about these difficult ethical decisions that they were making, that they were having to do it without guidance, that they felt like they didn't know what they were supposed to be doing, that there was nowhere to document them. And there was this really strong sense of kind of moral injury, this sort of fear of making the wrong decision and wanting some kind of support, either for someone to say, well, here's the right decision, or for someone to say, there isn't a right decision, but here's how we can move forward and help you with that. I think doctors were rightly concerned that they had no training or ability to document the reasons why a decision was being made, especially under the specter of rationing that was happening, and especially as some of these decisions they knew would result in the inevitable death of a patient. And COVID-19 has really changed the landscape within which we make these types of tricky decisions in healthcare. It was also spotlighting difficult decisions, and I think everyone knows we're always kind of there. And so this was an opportunity to actually help with supporting some pretty serious moral distress and moral injury that was being articulated across the workforce. And in doing so with some sort of practical support, and that's where we came about to our ethical guidance. So everything that we've been doing at the RCP has been under these guiding principles. I was pleased to see that we made the cut of 13 that Richard put up, otherwise this could be a really awkward follow-on conversation. If you've been reading any of our principles or using any of our guidance, these should be fairly familiar. Things like respect for patients and duty of care in particular should be familiar. Equity of care might be a little bit different. So health inequalities have finally come to the forefront with COVID-19, and we felt that there was an ethical imperative to consider these inequalities in any guidance, any practical support, any documents that we put out there. And we felt that frontline staff, policymakers, management, government, they all have a responsibility to patients to ensure that the systems that we use to assess patients and especially for difficult ethical decisions, don't actually disadvantage any group in any particular way. Accountability and transparency, I might argue that's been in short supply from our government, but it was another aspect that we wanted to create a system whereby we were ensuring that ethical decisions were sustainable and publicly defensible, and that they were open to scrutiny as well. That was quite important. Related is this principle of inclusivity. Richard's talked about it. We've heard about it a lot today, this idea that we need to be working with our stakeholders. We need to be understanding the needs of the people that we treat, but also the staff that we work with. We shouldn't forget that there's two sides to that coin. And then finally, this probably seems like exceeding common sense, but reasonableness was actually something that we realized was important to articulate, that decisions should be based on evidence, principles, and values that we could all agree on were relevant to the health needs in the context at the time, and that they should be made by credible and accountable members of staff. And so all of this came together working with myself, the registrar at the time, the lovely and legendary Donald Donahue, and John Dean, who is our clinical director for quality improvement and patient safety at the RCP. And we were working with the different doctors who contacted us, which eventually became the ethical care decision-making record and the accompanying guidance that we have about conversations for ethically complex care that we can find online. I think we're going to share those resources with you. Donald, unfortunately, didn't live to see us publish this in February 2021. February 2021, he died in January, but I really hope we did him proud on this because this was a really important part of his legacy. So, before I get too verklempt, what are we talking about here? So we developed this guide and it has 3 steps. The first is we want to define the purpose of the decision-making process. And we realized that this was quite necessary because that was part of what was being articulated when people said they didn't know where to start. They needed some help figuring out what the starting block was for these decisions. So we developed a table that outlines the factors that might be considered to sort of ensure the most appropriate and proportionate approach. And we defined 3 levels of complexity and sort of special circumstances in terms of standard practice, greater complexity, and special circumstances. And once the purpose had been defined, this helps us to develop a way to kind of facilitate a conversation about the decision that needs to be made. And that was something we really wanted to make sure that the record was able to do. This wasn't about a tick box exercise to fill in particular parts of a piece of paper. It was about helping guide people through what kinds of things they should be talking about, just getting them started. Because to be honest, for the most part, healthcare staff know this. It's just when you're in that particular moment, you just need a little bit of a nudge. And I won't go through this terrifying table. You can read it when you have literally nothing else to read. And then we were thinking about what are the possible approaches in terms of how we kind of get people thinking through the record itself. We were thinking about maybe using the 4-quadrant approach because of the had a recognition of the context and the complexities of care. But we realized that actually what we didn't want was we didn't want to make a tool that made decisions, which is what the 4-quadrant often offers us. We just wanted to create support for the conversations that led to the decisions. And so instead of using the 4-quadrant approach, what we did is we developed 4 key areas that we felt were necessary to start conversation, but you didn't have to go through each of these in any particular order. And so so what we've got here are the indications for medical intervention, the preferences of the patient's quality of life, and any contextual features. And so step 2 is really kind of going through this and using each of these questions to facilitate a discussion. And the discussion is the most important part here. The goal isn't to fill in the boxes, it's to solicit preferences. It's to understand the context within which you're trying to make these decisions. It's to understand the concerns, the clinical needs, and bringing that all together in one place so that everybody's on the same page and they're able to have a conversation where everyone's talking about the same thing. Often, the thing is, we do this already. Often we have these discussions. But what we were trying to do in response to the requests that we were getting was to provide a place where they were just documented together as a cohesive, holistic approach to care. And the thing is that when we have these sort of disjointed conversations across different parts of a hospital, as an example, we don't always know who said what or what's happened. And that was one of the kind of concerns that doctors were articulated, saying, well, what if I've missed something? What if there's something I haven't had that conversation with? And this brought it all to one place. And it also did another important thing. It showed that we had involved stakeholders, and it provided really helpful trigger points in terms of providing places to write down when we might review or revise the document or decision. Whether or not we needed to, this decision was only live for a particular amount of time, which was something that was also happening. There were so many changes in guidance and so many changes in resources that we needed something to help keep up with that. And so the third step is just to effectively record these conversations. So what was the decision in the end? What healthcare staff are involved with that? Because responsibility was something else that was coming up when we were talking to doctors. A decision might be made, but then who's responsible for it? How are we supposed to know who we go to if we disagree with the decision? How do we, if someone leaves and they're gone for a few days, what happens to that decision? And so in response to those workforce concerns, a key part of this is documenting the names and roles of all those involved in the process, and specifically things like clinical lead, as an example. And this means it's really clear, what the plan is moving forward and who's going to do which part of that, too. But we couldn't ignore the fact that there was this sort of resource allocation ghost in the room. And of course, what happens if resources are limited? Well, we kind of avoided that situation in 2020 when we were first developing this, but it's becoming increasingly clear that we might not avoid this in 2022 and moving forward. In particular because of staff vacancies and burnout across the sector. And then we've come full circle in a way with this guidance because the fears of having to make difficult decisions due to resource constraints during that first wave, well, now that staffing crisis coupled with burnout and the backlog in the system means that we may very well have to start making these decisions. And have to make decisions on resource abilities and not clinical best practice. So before I talk about just a little bit about what we did, there's something that we wanted to make clear, and we always shout about this, and that's that you're not responsible for making these kinds of decisions on your own as a clinician. At no point should a doctor be expected to take on the moral injury of making a decision that, they're not going to escalate an entire group of people for care in their hospital or their ward. That's something that we feel should be done at a national level, and there should be support across the board for that. These kinds of decisions have to be inclusive and they have to be accountable, and that has to come from that national center level. But if a decision was made for resource constraints, we wanted to provide some way of recording this as the quite major contextual factor that it was. And there weren't a lot of documents out there that existed in NHS where they were able to say, actually, I can't do this because of resource constraints. And so the record provides a space to record these important decisions, and even more importantly, any time limits or changes that can happen, because that restriction of resources could only be temporary. So I hope that this has given you, a bit of an idea of the types of things that we can offer at the RCP and how we can move from guidance and policy into more practical things, especially as we enter this road to recovery period. And I hope that this will be something that perhaps you'll use in practice and you'll take away to help you facilitate those very important discussions about really difficult decisions. So thank you.
Thank you very much. Right, so if we can rearrange without dropping the mic on the floor, if we can rearrange ourselves a little bit. do think of any questions you have and submit them, and they'll all become part of the feedback for the consultation, and they'll all be considered as much as we can. But I've got a question to start off with. The subject for this workshop is about what does it mean for regulators, and the current edition of Good Medical Practice it doesn't actually mention professional judgment as a phrase at all, and it mentions judgment in the context, clearly identified as being professional judgment once, with the advice that you ought to use your judgment in order to apply the guidance. And then there was a subsequent reference to professional judgment in the multi-regulator statement in March 2020, related to behaving, making ethical decisions during the pandemic. What does your research tell you that regulators should be saying? Should they say anything? The current edition of Good Medical Practice doesn't really say very much about what constitutes professional judgment. Does your research tell you that there should be a more expansive description?
I mean, I think one of the things that's been really clear over the last 2 years is that people want clarity, and they want to understand the boundaries of what's right and what's wrong in their practice. And that's why I think there's been quite a cry for sort of national guidance on a number of issues now. And, I think Richard hit it right on, nail on the head when he wrote, where is it? Where is it? Why don't we have this? We have nice guidelines for different bits of actual clinical practice. Of course, granted, they're implemented in different ways across different regions. But why can't we have this for practice and for judgment? Because judgment is very subjective. Is not the right word, but everybody learns it a little bit differently in the field, and they come at it in a little bit of a different way, and it tends to be related to the healthcare culture that they've grown up in terms of where they've trained and things like that. So there are subtleties there that if you have some sort of touch point to come back to, some sort of national guidance to come back to say, okay, am I within those guidelines? Am I within that area of that sort of spectrum? Then at least that you're headed in the right direction.
Striking question, isn't it? Should the regulator define judgment? Insofar as the research found anything, and it was a tether I pulled at to an extent, but we were sharply focused on the guidance rather than the judgment, but judgment fell out as a key question. I did find other professional organisations internationally, including a dietitians group in Ontario, I think it was, that did try and specify what judgment consists in and of, and broadly they pointed to, you're looking to knowledge, skills, experience, and what I would label essentially ethics or values. And it's broadly those four components, but you could, of course, in terms of each of those, then drill further in what do we mean by knowledge, what sort of knowledge. Mm-hmm. We had a reference in an earlier presentation and Q&A to best evidence, etc. So I suppose one of the things to ponder for the regulators, and indeed for the professionals who are regulated, is how far you want guidance to tell you what judgment is and how to exercise judgment. Is that something, for example, on the ground that there is a demand for? And I wonder, I think it's an open question at the moment.
It's interesting, isn't it, that one of the findings from the PSA report that we mentioned earlier relates to support, so professionals feeling that they would appreciate support, which might help them make better decisions or make them feel more comfortable about the decisions they're making. And then there was a slightly different finding related to how comfortable people feel about being regulated to make professional judgments, and is there, are they comfortable making decisions that they feel, do reflect a professional judgment, but then they will be judged for after somebody make a judgment about their judgment.
I think it is a bit like how long's a piece of string, and I think that guidance you're talking about that comes out of Ontario, that's probably about as specific as we can get, actually. There isn't, you can't drill down in the granular detail on a general level. And so it is a tension, I think, that exists with judgment, where in a way sometimes we say, well, use judgment. Well, what's good judgment? Well, you'll judge to know the good judgment, you'll know. And that puts a lot of pressure on the healthcare staff to somehow they have to know what good practice is and to know that their judgment is good. But it is tricky in that way. Yeah.
There's I think a good question from the audience about whether professional judgment. Well, I mean, the question, to be precise, is to what extent should professional judgment be a matter for individuals, and to what extent is it for teams?
I'm tempted to jump in outrageously and say, classic medical ethics answer, it depends.
Yes.
I'll take no further questions.
You took the words right out of my mouth.
Yeah, I thought I might. Sorry.
But it is interesting, isn't it? Because particularly in the context of regulation is usually focused on the individual, but actually, the work that you've described and the realities of clinical practice show that really a lot of these more difficult things it's hard to imagine that they would be better done alone.
Yeah, I mean, we could be less glib and say it depends on the patient, it depends on the team that day, it depends on the resources available on the ward or in primary or secondary care. It depends on the NICE guidelines, it depends on the regulators, but the context is really quite an important part of judgment. And that's why if you had the same clinical situation, but you moved that around the country, just as an example, the right answer would be slightly different everywhere you moved it.
There's another question about the limitations of guidance. They say, given the contextual nature of decision making, as we were just discussing, and the limitations of guidance in terms of being able to give tailored, specific direction, what more support could be given in terms of methods? So I suppose that relates directly to the work that you've been doing with the RCP.
Yeah, I mean, I think there's a few things. I mean, one is that we want to provide resources that are out there so that people have something to go to. If you are in a situation, especially 2 a.m., you've got to make some sort of decision, that there's something to get that conversation going, to help you with those first couple of questions about what you need to ask, maybe help you think about who needs to be in the room when you ask those questions, and about providing, I think, just really practical things, like places to write down what you found out and what the decision that you made, room in patient notes to be able to do that, to be able to hand over to teams if you're escalating or de-escalating care, so that people know how we got to this particular point. Because I think what was being articulated when we were hearing from doctors was the worries around that. Did I do enough did I talk enough with patients? Did I ask the right questions? Does the team that I've handed over to know those little things that the patient is really important to the patient that I know, but do they know? And it sounds silly, but yeah, pieces of paper to write stuff down is actually quite helpful, and questions to get you moving. For what I would say most of the workforce know how to have these conversations, just getting them started.
Could I add in that regard?
Yes.
I think this too is something to take back to the community, back to the professionals, and ask, to what extent do they want to be directed in forming judgments, and to what extent do they want freedom to reach and form said judgments? And I'm mindful, I think the work Alexis describes from the Royal College feels like it's striking in the right direction, because it's at least prompts for the conversations that need to occur. But beyond that, we know people vary in their reactions to check boxes, tick boxes, different forms to fill in, and there is something of a perception, certainly from my side, of form overload. There are too many forms, too many processes. So there's a balance to be struck there between guiding people and at the same time saying, well, you are professionals. So reaching a judgment is actually part of what strikes you out as professionals. I don't mean strikes you off, I mean strikes you out. But having made that terrible pun inadvertently, I think that might be one of the elephants in the room, is are we really asking about support for reaching and making judgments, or are we really hearing that we need more support for people who have made judgments and perhaps some complaint has followed or something has gone wrong? What is really being looked for here? Help for judgment, or help for the after effects of a judgment and perhaps adverse consequences. And I just wonder if the latter might be driving some of our conversations, rightly or wrongly. Well, it could be, yes.
You know, I don't think it's unreasonable for the workforce to be worried about whether they made the right choice and what the consequences mean for them. And we haven't been very good at supporting them in terms of that. And context is incredibly important when we deal with complaints as well. And you know, I do think part of this is about moving it downstream as well in terms of how we actually educate our workforce at the beginning, in terms of preparing them for the kinds of situations they may be in, and bringing that education earlier in terms of, you know, these are the types of decisions you have to make, these are the people that will have to be in the room. Because in ethics, we do focus quite a lot on principles and theories and you know, often case studies that will never actually happen in practice. And I mean, less so in different universities, but that sort of on-the-job, a lot of doctors talk about just having on-the-job training with ethics, where that's the first time they're really encountering having to make these difficult decisions, having to use their judgment, and then questioning whether that judgment was right. And is there a way for us to move that education a little bit earlier so that it's sort of less jarring when they actually hit those real-world scenarios of being in practice?
That makes me think of the section of your RCP decision-making record related to accountability, in that I think that there is one aspect of making a judgment, and there's another aspect which relates to the ability of you to explain it to other people or other people to explain it. And I wonder how much of that is something that drives a lot of the concern that practitioners might feel about making judgments. Sort of, they make a judgment, but they're perhaps not used to explaining it or expressing it in those terms.
Yeah, and I think maybe having more conversations about the two-way street of accountability as well, and one of the things that I know we've had good feedback on for the record, because we've been asking for feedback from people who are using it, is that they do like that they're able to write down that process of how they got to the decision that they were making, and that writing down that process helps for that accountability. So anyone else who goes back to look at that decision can say, oh, okay, well, this is how we got here. You know, right or wrongly, this is how we got here. But also, it's an accountability for themselves. They're able to write that down and go, okay, no, this feels like good judgment. It's that self-reflexivity that we don't allow for a lot in practice, but it for the most part, I think doctors and nurses they're very, and all healthcare staff are they're good at that, actually, of going back and going through their own checklist of what they know to be right, and just providing that space lets them do that.
So we've hopefully got time for a couple more questions. A question from Deborah Bowman is, I wonder whether ethics education development focuses on content with less attention to reasoning, analysing, weighing up cognitive skills that might inform judgment. I suppose that's very related to what we were just speaking about.
Yeah, I'm very taken by that question. Thank you, Deborah. It's something that we, in Bristol, so I'm based in Bristol Medical School, and we redesigned our curriculum some years ago. And there's been a great deal of discussion with colleagues about the extent to which we include critical thinking type skills and the like. Now, oddly, I think Deborah is right insofar as a great deal of the ethics and law teaching that I lead along with colleagues is very content-based. It's the Mental Capacity Act, it's these theories. We attempt to try and walk them through and show them how to apply certain things. We give them lots of opportunities to do so themselves in small groups, including without staff present, which I was terrified about initially. Went way better than when you do have staff present. We found the ethical reflection was deep. You could see the workings that you were referring to in the previous question. But I do think you're right. I think there's more to be done there. So I know that we do in the intercalated program level a great deal of thought about how to form a good argument, how to reason, how to show your workings. I wonder being candid if we're doing enough about it within the core professional program.
I think critical reasoning, just as a skill on its own, needs to be hugely amplified in medical education right now. And in particular, because in the first 2 years they don't get a lot of opportunity to use it, and then we chuck them out into hospitals in the 3rd, 4th, 5th year when they've got to learn on their feet. And if we could provide them some more safe spaces to try that out, just as you were talking about, I think we'd A, be very pleasantly surprised, and B, we'd have given them an opportunity to learn that, because it is I think that critical reasoning is a really tricky skill, and sometimes we forget how young our students are when we get them. My first year medical students are 18 years old, and they are, I know they're adults, but they are basically babies, and there's a lot of them are outside of their world for the very first time. They're living in a whole new city, they're seeing a whole new culture, they're seeing a whole new world, they're meeting people that they never would have met outside of their own particular demographics, and that will be their whole medical life. But that is a time to help them to sort of learn that critical reasoning and really get that out there. And I think if we could nail that a little bit earlier, we would also help with a lot of the moral distress that is articulated in the profession right now.
It's a rather specific question related to education again. Do you think that medical students, and perhaps not just medical students, perhaps people like me who also have to make these decisions, would benefit from scenarios, records of decisions that had been made by other people in the same way that a lawyer would have access to a judicial decision, but also the reasoning behind it as written?
I think, yeah. I mean, so a while back I did some research on how medical students actually learn to make ethical decisions, and junior doctors and consultants as well. And what was really interesting is that most of them had nothing to say about the lectures that they did in medical school, about any of the theories that they learned, or the cases that they had to go through. What they learned from was by watching other doctors and seeing how they handled situations and identifying that was a good way. It was a bit like case law. It was like, oh, that's a precedent now. So next time I come across a situation like that, I want to deal with that the way I saw this particular doctor or nurse deal with that situation. And all of them, it was uniform across the board. We talked to over 120 odd people, and every single one of them talked about how that sharing of stories and the watching was really how they learned. And I think that we have to pay a bit more attention to that, because we know that storytelling, we know that sharing in that way is how most people learn quite universally. So why are we not applying it here in the highest stakes?
Yeah. So I think we've got time, hopefully, for one more question. And it's about the relevance of the unusual circumstances around the pandemic. So both of you have done work around the pandemic. All of our clinical practice has been completely upended by the pandemic, and it has, I hope, triggered a long-lasting interest in ethical decision-making and the support that we can do for that. Emma Cave asks how important it is to build on that now.
Yeah, hugely so. I mean, I was heartened, if I refer specifically to the clinical ethics support services out there, so briefly donning in part my UK Clinical Ethics Network out, I think it was heartening that we saw so many services springing up, and we certainly had a great many requests to do so. And we did our best to pair them up with more established groups so that it was learning across the piece. But there is still that quite confused whole system and structure. And I was seeing, and this is a personal reflection, not as chair, committees being stood up quite quickly and then stood down quite quickly and then re-stood up again with a different name. I think we could probably do better. We can make it, as I said in the presentation, clearer, more accessible, so that we can learn together collectively to move forward through that fog I referred to.
Yeah. I think just a recognition on a wider level as well about the importance that ethics has. Sometimes I think we think, often medical ethics can be viewed in a couple of ways. One is sort of a thing you have to do, because we know that that's for good practice. And from a clinical ethics point of view, it can be viewed as a sort of hoop you have to jump through in order to get something done. But the pandemic's really sort of crystallized the fact that we need to think about this stuff all the time. It's always there, and the pandemic's just really concentrated that, really put a spotlight on what those difficult decisions look like. But of course, the difficult decisions that we were hearing about during the pandemic, they were pandemic specific, but you could have taken the word COVID out, and you would have found a situation that someone had lived through that was like that. And so really we need to be thinking more about how ethics is part of everyday practice, and how do we support ethics every single day in a really practical way, so that people feel like it's not just something that they're paying lip service to, it's not just a hoop they have to jump through, but it is an important part of good clinical practice.
Well, thank you ever so much. I think I'd like to offer my thanks to both Alexis and Richard for joining us today. And unfortunately, we've come to the end of this session, but if we could flick through to the next slide, I think there's some information about how we can access the GMP consultation, which it's obviously not solely devoted to thinking about professional judgment, but there is some slightly expanded wording around the meaning of professional judgment, and any opinions or information about the role of professional judgment in the advice given by the medical regulator, I think would be of great interest to the team. But thank you again, Alexis and Richard, for joining us.